I'm delighted to welcome our next speaker to the second OncoConnect Symposium. We have the privilege of hearing from Sami Mansfield, a distinguished figure in the field of exercise oncology. Sami Mansfield, hailing from the USA, is not only oncology exercise specialist, but also a consultant. She is the founder of Cancer Wellness for Life, and her career has been dedicated to empowering both cancer patients and clinicians alike. Her influence extends far and wide, touching the lives of individuals within cancer centers, hospitals, and beyond. Sami has played a pivotal role in shaping state cancer control plans and has co-authored vital guidelines that have made a significant impact. Moreover, Sami is a dynamic public speaker, generously sharing her expertise with the world. In 2016, she introduced BUILD, a transformative fitness program designed specifically for cancer survivors. Welcome, Sami. The stage is yours.
Hello, everybody. I'm Sami Mansfield, founder of Cancer Wellness for Life. And I want to first thank Dr. Nigar and the entire MedSynapse team for inviting me to the OncoConnect discussion this weekend to talk about the very important topic of exercise oncology. So let's go ahead and get started. So it's really important as we move into this discussion today that we start with key definitions. There's so many words going around about talking about exercise and physical activity that we really want to start here with a focus on exercise. So let's first take a step back and think about wellness. Wellness simply is all about healthy lifestyle and the specific act of practicing healthy habits on a regular basis. So this can be really simple, such as drinking water, getting good sleep. And it can also be things, again, like exercise that we're going to talk about today, as well as nutrition. In the cancer setting, we use wellness as thriving while surviving. No matter if you are in treatment or living with advanced disease, we focus on wellness as healthy habits after a diagnosis of cancer. Physical activity is a very general definition, and while it has been researched significantly, it is something that is much harder to define, and therefore we're going to move past it. But before we do, let's make sure we understand the differences. So physical activity is simply any movement that we perform daily. So this could be exercise and things like walking, but it's also things like getting up, taking a shower, making your breakfast, doing a load of laundry. All types of movements is designed to be physical activity. The difference is that physical activity and exercise is that exercise is movement with a purpose. So it, again, can be structured physical activity, but can also be something like physical therapy or any form of rehabilitation. It's just having a plan of a type of movement to improve health and fitness, or as I mentioned, a means of therapy. It is also important for today to discuss specifically what is fitness. We do see this, especially in community-based settings. Fitness is actually an outcome. So fitness are characteristics that individuals would achieve related to muscular strength or endurance, cardiovascular health or well-being, as well as things like body composition, flexibility, as well as balance. So what are the guidelines for cancer survivors? Well, it's important to note that although these are specific guidelines for cancer survivors, these are also the guidelines that are recommended for any adult living across the world to strive for. I think it's important to talk about specifically what they are, as well as why they're important, and then we're going to dig a bit into this from a cancer specific focus. So the guidelines are simply 150 minutes of moderate or 75 minutes of vigorous related to intensity exercise each week. This breaks down to, as an example, if you're going to do 22 minutes a day of moderate, 15 minutes a day of vigorous, you would accomplish that. But it's really critical to mention, and this is actually new as of 2018, that we have added the importance of actually strengthening exercises for our cancer survivor population. So there are a lot of benefits of doing aerobic only or strengthening / resistance only, as well as combination that you see on the right. Things in research that we have studied, such as anxiety, fatigue, quality of life, bone health, etc. What I think is really important to note is that the more that we can encourage our cancer survivors to strive to meet the overall guidelines, the more benefits that they're going to achieve. And just because a benefit it may not be listed here doesn't mean that this meeting guidelines doesn't actually prove that benefit. We just may not have the research to show that in a cancer specific population. So I think it's important to note that although these were the guidelines for anyone living after a cancer diagnosis, recently ASCO, which is the American Society of Clinical Oncology, produced a guideline just last year in 2022, where we reviewed should we have someone with a cancer diagnosis on treatment exercise? And I'm happy to say, as being part of this author team, we reviewed all of the evidence. It was overwhelmingly supportive that for patients on treatment, any kind of treatment, this could be IV chemo, surgery, radiation, radiotherapy, immunotherapy, whatever that may be, if they were on treatment of curative intent, we should encourage these patients to strive to meet these exercise guidelines. This was also the first time that we stated from ASCO that we should focus on prehabilitation exercise in surgical lung cancer. So these are patients that we know will be undergoing some form of a surgery. Maybe it is a surgery only patient or a patient that might be going into chemotherapy or radiation. But at the point of diagnosis, even before a treatment, they should actually start an exercise program. And again, we're going to get into what does that mean, but this guideline was the first of its kind throughout the world that we actually made this recommendation in this very key time point. So exercise is simple, but not easy. So on the right, you see what I call the activity pyramid. We see that on the bottom, we really want to focus on increasing the daily movement of our individuals with cancer, no matter where they are in their life. Then we focus on that middle standpoint of meeting these exercise recommendations, again, getting regular exercise of aerobic and strength. And you can see my person kind of on that middle on the right is actually doing chair-based exercise, which I will also come to during this presentation and the importance of that. And the key piece of my activity pyramid here is we want to reduce what I call true downtime. This is sedentary behavior that is not any form of activity or movement whatsoever. So this is sitting in the chair watching TV or reading passively, lying in bed, napping, again, watching TV or even resting. So it is important to say that although not every individual with or after a cancer diagnosis can do vigorous physical activity or go to the gym, we want to focus on reducing that downtime and finding the right intensity for these individuals. So we can see the goal is to increase overall physical activity and exercise while we reduce inactivity as well. So on the left, I just give a couple of examples of what does this mean and how does this translate into the real world. So take a moment and think about this for yourself. So maybe you haven't been exercising, you just haven't had that kind of, regular regimen, and you're wanting to strive to meet these guidelines. Well, maybe you want to be a moderate exerciser. You don't want to do vigorous intensity. It's not something that you enjoy. Where do we start? Well, this is a really simple example. Just walking 30 minutes at a brisk pace, something that, your heart rate comes up, but is really quite comfortable. You can actually carry on a bit of a conversation. If you do that for 30 minutes, 3 times a week, you're almost already there. The most important thing is, if you're going to do that Monday, Wednesday, Friday, on Tuesday and Thursday, that's when we're going to get those 2 days of strengthening. And again, all of us, especially our cancer survivor population. So if you simply do 8 targeted exercise times 10 reps, and you complete this for 2 to 3 rounds, this is going to take you between 20 or 30 minutes. That example alone, you can check off that you have met those exercise recommendations. Now, maybe you want to make a little bit more of an effort to do vigorous intensity exercise. There is benefits of this for how we feel physically as well as mentally. Maybe you want to get done in less time. Here's a really simple example. So rather than take just a general flat walk at a brisk pace on Monday, Wednesday, Friday, let's go ahead and actually take this to be hilly or a stair walk. Maybe you want to start jogging or doing an interval stationary bike at home. Maybe you enjoy that or the weather is inclement. 15 minutes at that more intense effort, you can be done again, meeting your recommendations. And then we want to think about on Tuesday and Thursday, more efficient strength training exercises using multi-joint or what I call compound exercises. So you're actually maybe adding a shoulder press to your squat, or you're adding something where you do a lunge and maybe you add a push-up or something to that effect together, or you do bursts of exercise. Again, this is a really simple way to get more work in less time, a little bit more intense, but again, simple way to meet those exercise recommendations. So what else do we know about the benefits of exercise? I want to bring up some of the specific populations here. Interestingly, the data has actually been updated since I created this slide several months ago. So I would actually probably even add a couple of things now, but let's go ahead and talk about these very interesting areas as well. So we are starting to see in preclinical models, starting now studies in human models, looking at exercise plus chemotherapy and related to pancreatic cancer and outcomes. We are seeing that exercise improves tumor vascularity. This allows the pancreatic tumors in these particular models to uptake more of that chemotherapy. This is usually with our Gemzar, Gemabraxine regimens, but we see that this can improve the outcomes in our patients, and then again, helps reduce fatigue and other functional changes. So it's a nice recommendation for benefit in survival as well as overall quality of life. We know that exercise does not contribute to risk or exacerbation of any breast cancer associated lymphedema. This has changed actually in my career of 20 years. 20 years ago, we were very fearful of lifting anything over 10 pounds for the rest of the lives of our breast cancer survivors. And now we know that actually exercise does not increase risk, and most importantly, can actually mitigate or reduce risk by improving how that lymphatic fluid will pump by adding more muscle. So it's really important to kind of think about this when we're working with patients and individuals or practitioners that may still be on old recommendations, and things just like treatments are changing very rapidly. What else do we see? Well, in advanced cancer, we know that cancer cachexia, which we realize is responsible for many deaths across the world, those patients that become very sarcopenic, very ill fast, and can just die from this particular condition. We know that moderate intensity exercise can reduce the severity of the muscle wasting, therefore slowing down the decline physically and the loss of muscle or sarcopenia, and reducing risk of cancer cachexia. We know that in a lot of our patients, or I'm sorry, in a lot of our disease types, especially with metastatic cancer, we see patients do better when they move more. Well, the evidence on this is actually starting to show up in key populations such as metastatic colon. We know that exercise improves not only the length of life, as well as quality of life in simply moderate amounts. And then most importantly, and I know this is a key question we ask every day, how does exercise improve the mental health and well-being of our cancer survivor population? We know that there are reductions in anxiety, depression, and sleep disturbance, especially related to things where people are on certain treatments that may change how they sleep. They have a lot of anxiety related to their treatment or financial toxicity, or they're worrying about how long they're going to live. We see general quality of life. However, only in the last 6 months, we are starting to understand specifically that exercise in the general population actually should be recommended as one of the first line therapies for depression. So instead of just treating our patients with medication, we know that if we can also get them to exercise or start with exercise if they're not at high risk of something very severe, such as suicide, we know that we can make improvements without giving them an extra prescription. And therefore, they're not dealing with the side effects or the costs, et cetera. So again, we didn't 20 years ago have the benefit of exercise and mental health. We just knew people feel better. And now we have significant quality studies looking at this. So taking a look, this slide's a little bit content heavy. I want to start on the left. It's really important to think about the practical benefits of exercise. So on the left was a study that was published 2 years ago in the British Medical Journal, looking at how meeting the exercise recommendations I brought up at the beginning, the 150 minutes of moderate plus resistance improved mortality. So all-cause mortality was down by 40% for individuals that met those combined recommendations. Cancer mortality goes down by 46%. So when we're working with individuals wanting to not die from their disease, we need to start saying exercise is another tool in your tool belt. And we now have the evidence of this. Yes, these are retrospective studies. However, they're still really critical in making these recommendations overall. From a practical standpoint, worried about financial toxicity, which is prevalent across the world, we know that individuals that meet these exercise guidelines have 36% less health-related costs out of pocket. This particular study that I'm citing with this number is from breast, prostate, colorectal, but we are starting to see this also in other types of cancer, such as blood cancer and some of other complex GI cancers as well. You can also see in the middle, we're looking at improvement of virtually every single side effect that we in the clinical setting focus on every single day. So we know that the benefits are significant to strong in each of these particular categories as well. It's also really important to note that we can reduce risk of recurrence by 48% in all stages of breast cancer. And for our women who are meeting their guidelines at diagnosis, they have 55% less likely risk of recurrence. And actually, a new study just got added where we are seeing benefits in progression-free survival. So I would say when we look at the slide, we need to ask ourselves, is there any negative side effect of prescribing and recommending exercise even in small amounts? And the answer is no. So I think it's really important to remember that it is not just a nicety, it is truly a necessity to bring up exercise in our conversations. So how do we do it? Well, there's two sides of this equation. We know that sometimes we don't have the resources that we would like to be able to deliver these programs, and that is okay. We have to start somewhere. So I have sort of two sides of maybe where do you start when we think about exercise and integration into clinical healthcare. One is what I would say is signature. It would be my ideal recommendation, connecting in person with everyone that walks in the doors. This could be through an exercise oncology professional, a trained nurse, or another staff member that has this interest. It doesn't have to be exercise oncology, although that's very beneficial. Doing in-person assessments, determining where an individual is at, making an exercise prescription, what is the recommendation for somebody that's in front of you, and creating an intervention that is at the time point that they're at. Encouraging our patients to meet exercise guidelines. And I would add their caregivers, because we know caregiver health is important. We want to think about integration into multidisciplinary care. So not just the physician, the advanced practice practitioner, and maybe the nurse. It's thinking about how we all work together, how all of the providers work together, and perhaps thinking about, as an individual provider, how I can put exercise into my conversations, whether I'm a medical oncologist, I'm a surgeon, I'm a radiation therapist, a nurse, whatever that may be. And we're making sure all patients get referred to these programs and thinking about having access and coverage from a standpoint of cost and finances, as well as where are we delivering these programs. We know that we can do virtual now. We know that you don't have to always come into the clinic. And we don't always have to look to insurance to pay. There's a lot of ways we can integrate into care. Now, maybe a step down is thinking about comprehensive care, where we're providing exercise education, information, resources out to community or virtual. There's online resources, there's YouTube resources. We have lots of resources we can use. And thinking about providing general resources, such as sample exercise programs right in that clinic. They could be cancer type specific, or they could be related to something, as I will show you, in function. It can be very personal to how you want to deliver your care. The goal in comprehensive care is to decrease inactivity and increase exercise. Not really worrying about guidelines necessarily, but just focus on shifting the conversation to improve the quality of care and outcomes for all of our oncology patients. So here, providers, we need to communicate with you. We need to respect both the provider role as maybe the community role. And I think although we may not be able to always sit at the same table, it's important to note that we need to understand where we can deliver this care and where maybe we have gaps and refer on. And it's important to think about it doesn't have to be perfect to be successful. We might need to find shortcuts and workarounds and really leverage community resources. And there are many community partners that exist across the world in exercise oncology as well. So here's a couple of things thinking about the day-to-day practice of exercise oncology. So we look at the big three. We look at someone's function. Are they able to get up out of the chair? Do they need a walker? Are they ambulating with some form of assistance? What are they exercising right now? Are they even walking their dog or doing a YouTube video or doing something like yoga? Are they doing planned physical activity? And what is the amount of inactivity that they're doing every single day? And I think it's important to think about for us, as an example, we may realize that although I'm exercising, I'm meeting my recommendations for 30 minutes, I'm not doing anything else for the rest of the day. Therefore, my overall inactivity is quite high. So these are considered to be what we kind of call the big three. From there, we look at our symptoms. Energy, fatigue, again, functional changes. Are they having pain? Are we having body composition changes? A lot of fat being gained, a lot of muscle being lost. These are all kind of things that we can kind of tap into, whether we're an exercise oncology professional or in our clinical oncology healthcare. Asking questions about how they're staying active. Are they exercising? Tell me about your day. What do you like to do? Are you going to the gym? Are you doing a YouTube? Are you doing something at home, going to physical therapy or physiotherapy, whatever that may be? And then giving recommendations and preferences based upon these big three. We utilize a functional assessment in my world where we test balance, grip strength using a dynamometer, very low cost. We can actually buy these for typically less than 25 US dollars. And they're very evidence-based and easy to use and kind of fun. Lower extremity strength. Can, again, someone get out of the chair or step up if we want to test them onto something like stairs, because we know our patients may need to get on an exam table or up onto the radiation table. They need to get a scan. So that lower body strength as well as core is key. And then thinking about upper extremity range of motion, especially related to some cancer types such as breast or head and neck, sometimes lung, but also based on where our ports are and thinking about making sure we're moving those muscles, we have good posture, etc. We utilize some standardized tools such as a dynamic gait index score, circumference measurements, as well as standardized measurements of upper body strength. Often we use a countertop push-up. How many countertop push-ups can you do in 1 minute? That's a great way to assess upper body strength right in your exam rooms. So the prescription and intervention we take looks at what we call the ACT patient classification, which I'll come to in a moment. We also take into consideration function, fatigue, exercise, and also motivation, thinking about where a patient is and their interest also to exercise. We do incorporate performance score because we work in healthcare. So often we will incorporate ECOG or Karnofsky into our assessment. Therefore, we are speaking the language of the clinicians and we're all focusing synergistically on where a patient is functionally and making our recommendations. So this is my favorite simple assessment to use with any one of us. So we do utilize what we call active, which is a 5 times sit to stand to assess function. This is a very slimmed down version of the rehab 30 seconds sit to stand or a timed up and go test, which are validated tools that you can also use. But we utilize just a simple 5 time and we categorize the patient in either action, challenge, or train. Therefore, it's our active assessment. So can the patient do it? If they can't, or they need a significant amount of assistance, such as really using their hands on the chair or a walker, we categorize them in the action category. You can see here that the recommendation is don't worry about meeting the 150 minutes, strive for 10 minutes total of daily exercise. We probably will refer them to a rehab setting for an evaluation and also some guidance and motivation. If they aren't really interested in going, that happens a lot, or maybe they don't have the costs or the dollars, the transportation or insurance coverage. We're happy to give them chair-based exercises, maybe balance, something that we feel that they would be safe in. As you can see, if someone can do the 5 times sit to stand with minimal assistance, maybe a little bit of that I burn in my legs, then we will really focus on striving for 15-minute exercise sessions, working them up to recommendations, alternating aerobic and strength. We can offer physical therapy. Sometimes patients really want that personalized plan or virtual resources for exercise. And then the education we would give them is what we call strength progressions. We're not worried about them falling necessarily, but we still want to keep them safe and progress their strength overall. If they have no difficulty, they're popping right out of the chair for those 5 times sit to stand, then we say, you know what, you have no limitations. I want you to strive to meet those exercise recommendations, encourage intensity, encourage variety, encourage them getting full body movement, encourage them to get those recommendations, offer to provide resources. But honestly, that is somebody that really doesn't need supervised exercise. And they can often work really well in a community setting where they don't have to feel like the cancer patient. And I think that's really important as well. So, what does a day look like in the life of an exercise oncology professional? Well, we do a lot of medical record review. We need to understand what a patient may be on from a medication side. We need to look at their comorbidities. We need to see where they are in treatment cycles or where their kind of plan of care is. We need to maybe sometimes look at lab values. Are they having low white counts or is their hemoglobin okay? And so, this is a lot of what we do, a lot of patient care and communication. Often it's communicating with the healthcare team and making sure that everybody is not only on the same page, but being a support arm for a physician or a nurse or other healthcare professional that wants to make these recommendations, but is sort of learning how to do it or wants support and making maybe something a little bit more personalized than just striving to meet exercise recommendations. I think it's important to say you don't need a gym to prescribe exercise. Although we need to keep people safe and use our clinical judgment, it's really important to also encourage someone that just wants to maybe start at home. Maybe they feel comfortable starting at home. Maybe they're nervous of going to the gym. They're not really sure if they want to commit to an appointment. They want to be able to do this while they can. Totally okay. Our goal is to reduce inactivity and give someone a safe place to start. It's really important to meet people where they are at, having that motivation for success. If they want to start with 10 bicep curls a day, I think great. If they want to start with, walking one loop around their house or one flight of stairs or a yoga video, again, great. Starting someone where they want to start is key. If we can work people up to meeting recommendations, great. But starting where that person is today and maybe where they are in their treatment cycle or their survivorship cycle is also critical. So I'm going to provide an opportunity to kind of look at 2 case studies. So this particular case study is a lung cancer, stage 4. Complexity score, we're not going into detail, but we utilize a function and comorbidities to create a general score of complexity. And I can share more about that. If anyone's interested, you can reach out to me after this presentation. But we really look at what side effects is this individual having. As you can imagine, it's typically many: fatigue, anxiety, sleep. Maybe they're not eating. They're probably losing weight. These are all side effects that we know where the individual is at. What's their functional level? Challenging. Remember the challenge category? They're kind of in that particular category. They can kind of do the work, but it's very difficult for them. Not exercising. Motivation, as you would often expect in this particular population, is high. I want to do everything that they can, but they're scared. And remember, when we're taking on individuals that have lung disease and we ask them about shortness of breath, there is going to be shortness of breath in this particular population because of disease. But also, when we're starting someone from a deconditioned state and we start them exercising, they're going to breathe harder. This can cause anxiety. This can cause a little bit of fear. So I think it's really important to note that we are working with an individual that has disease and potentially side effects or treatment effects in the lung. So we need to address that in working with this individual. So what do we do? Well, honestly, when we're working with a patient with lung cancer and some of our maybe, again, cardiopulmonary type diseases, we actually often start with resistance first. Why? Well, I want them to move around. I want them to do their ADLs, but typically this is a population that's lost a lot of muscle mass. And therefore, we want to make sure that they're getting that muscle mass back on. This is also a population we see a lot of use of immunotherapies. Side effects of immunotherapies are typically treated with corticosteroids, which contribute to muscle loss, and therefore that muscle loss is increasing our fatigue and decreasing our function. So I often start these individuals with resistance over aerobic first and really encourage them to meet all of their activities of daily living. And if they feel good, take a walk, get on a stationary bike, do some form of exercise that feels good to you. Nothing is technically off the table. This will maybe need to take into consideration where that disease has progressed to. If it's in the brain, we need to focus on balance. If it's in the bone, we need to make sure that we're loading those bones correctly, but encouraging our patients to still meet exercise recommendations, which we know are safe. But again, starting point, definitely focusing on resistance training. So my next case study is actually thinking about a head and neck, which is a stage 2. And I have a comparison here to a rectal stage 2, but I want to think about something here. I have maybe low complexity. So I have a head and neck stage 2 complexity scores of 4. So again, on the scale to 10, not too high. Their ADLs are good, but this individual is fatigued and just very sedentary. And we know the fatigue cycle, once they get on this cycle, they're going to keep going down and not going to gain energy until they get moving, not just get off treatment, but get moving. They're not exercising, and honestly, they have minimal motivation. Where do we start? Well, this is a particular patient that if they are very fatigued and very sedentary, I would really recommend that they start with physical therapy or occupational therapy, focusing on a little bit of motivation and adherence. If they are unwilling, I'm going to start them with some form of chair-based exercise because I tend to think that the intensity is going to feel very doable. They're not going to feel very overwhelmed. They're not going to feel like they're straining their body too much. And that's going to help them create a little bit of motivation without feeling like overwhelmed or they have to strive too hard to meet those exercise recommendations. On the other side of things, I have a rectal stage 2, low complexity, functionally very active, can move around, do everything they want to. They're exercising regularly and their motivation is high. What do we do? Well, in this particular individual, I would definitely dig in where they are in exercise recommendations. If they're getting both aerobic and strength, make sure we're getting the gaps in there. But one thing to consider about rectal patients, especially in the past, we're treating them often with surgery or radiation in that pelvic area. These are individuals that often have pelvic floor challenges. And so if they want to go back to an exercise regimen that might be a little bit more vigorous, they might have bowel or urine leakage or just pain or discomfort. So often with a rectal stage 2, I make sure that they have access or referrals or education to some pelvic floor therapy to support their goals of staying active and exercising regularly. So although it's not about meeting recommendations, it's about the potential side effects that have come from the treatment that we want to make sure that they're actually meeting as well. Important on all of these, use your clinical judgment. We don't care about perfect. We need to focus on a starting point and a communication strategy. So lastly, I want to say exercise really is for everybody. So for patients and caregivers, we know that there's less disease burden and reduced side effects, as well as mental health and cost savings. But really key in remembering that in the world, we have an estimated almost 40 million cancer survivors. I believe that's right. And we want them to feel like they're done and they've recovered. Often they come in and they might have been at a certain level, they go through the treatment trajectory, and the expectation is they're just going to come out the other side and be okay or take time to recover. We know that this isn't the case anymore. The majority of patients, something like 80%, are reporting that they don't feel even close to the same that they did when they started. And there's a lot of reasons to this, and not everybody will get back. But the earlier we can prescribe exercise, the less side effects the patient will have. We can mitigate many of these common side effects and really empower them to live the highest quality of life and survivorship or with an advanced cancer as long and well as they can. For the clinical team, physicians, advanced practitioners, nursing staff, social work staff, dietitians, whatever that may be, we know that exercise creates reduction and management of many common side effects. So rather than have 50% of your patients call for fatigue and we say that's normal, let's intervene early. Let's reduce the amount of fatigue that we're managing with our patients so we can really focus on true clinical needs where a clinician is really required to support the patient through this experience. We need to educate staff on the value of exercise and also how to do it, because I think that often we think, oh, we need to go to a gym. And we learned even before COVID, we didn't, but we definitely have been able to reiterate that now. It's important to implement wellness and function at the clinical bedside and triage early. Thinking about this even from an inpatient side, it doesn't have to be when someone is feeling like it. It is our job and responsibility to support them from the beginning. If we know the road that's coming, let's get in early and at least start having the conversation with the patient and, importantly, the caregiver, if that is available as well. And then lastly, for health systems, there is so much evidence understanding that there are reduced hospital and healthcare costs related to patients who exercise and meet these recommendations or even go to physical therapy. We know in the United States, there's a lot of, with patients that are readmitted, there's no reimbursement with it. They're readmitted for the same diagnosis within 30 days. So this is a way to keep our patients out of the hospital. It's a way to keep our patients out of the ER. We know that this reduces their fall risk. They're easier to care for because they move better in the clinic. They move better at home. We know that these patients do well and they're less of a burden on our healthcare system and on our staff. And then lastly, we know that there is definitely in cancer a lot of evidence looking at reduced length of stay, visits, as well as triage needs. Again, my comment earlier, if patients are feeling better, they're not always calling the triage line looking for support for things like fatigue that can be managed or just kind of made common. They are definitely living a higher quality of life and therefore more like a cancer survivor, no matter where they are. All right, so I'm going to wrap up here to provide my contact information. And you can see here is my email and then my direct contact information if you want to utilize from a US, from WhatsApp. And then lastly, I want to add, exercise is no longer a nicety in cancer care. It is an essential component of the clinical care plan. And you, by listening to this presentation, are part of making this a reality. Thank you so much for having me. And I hope you'll reach out if you want questions or you have questions, you would like to review any of the evidence I presented or would like to review any of the resources.
Thank you, Sami, for your very interesting presentation. We truly appreciate your participation in today's symposium. Now, as we move into the interactive part of our event, we have two thought-provoking questions from our audience. So the first question is, how can doctors effectively incorporate physical activity into their treatment plans for patients undergoing cancer treatment to enhance their overall well-being and recovery?
So this is a great question because, as I mentioned, one of the most important things about exercise, as well as physical activity and fitness and wellness, is to start early and integrate right into the cancer care plan. We don't want this to be separate. I would really recommend that anyone working in the clinical oncology side really maybe understand the basic recommendations and feel confident that the evidence is there for safety and efficacy, but we don't care about patients meeting exercise recommendations. What a patient is going to care about from you is understanding how exercise is going to improve whatever side effect or concern that they're going to bring to you. So I'm going to go back to fatigue. Well, we know that fatigue is the number one side effect, and there are definitely clinical reasons of fatigue. We see this in things like blood counts, medication side effect as well. But something like 75% of fatigue can be improved for patients on treatment with physical activity and exercise. So if a patient brings to you, hey, I'm really fatigued, I'm having a lot of concerns with fatigue or sleep or depression or anxiety, tie in the role of exercise and physical activity to that particular side effect. And therefore, that patient will begin to understand that they are connected and not separate. I think it's important to have the conversations, but not have to own everything. If you can have a conversation of, 3 to 5 minutes, great. But I also understand that most clinicians do not have this amount of time. And so, can you leverage having a printed resource? We do educational collateral for clients all of the time. And part of that is I'm a breast oncologist and I have 15 minutes to talk to my patients. What's something that I can give them so that they can get ready for surgery, recover from surgery, not increase their risk of lymphedema, manage their weight, whatever. And so that curated content piece is something that I do every day and is really critical because then as a clinical provider, you can just hand it out. The most important thing is include it in your conversations and tie to the side effect.
Thank you so much for answering our first question. We also have a second question. What strategies and approaches would you recommend for healthcare professionals when dealing with emotionally unstable cancer patients who are unwilling to participate in exercise therapy? And how can we help them overcome their reservations to benefit from physical activity?
Okay, so this is a great question and a much more difficult question. Often, when I'm dealing with an individual or a caregiver who already has a bias against exercise, as well as perhaps mental health challenges, maybe I'm just too depressed to exercise, which is very real, even though we know the evidence shows the benefit. I think one of the things to reframe the conversation is find out, are they are they able to do the things that they want to and need to do in a day-to-day basis to live their life? As an example, do they live in a two-bedroom home, bedrooms upstairs, maybe laundry's on a different level or the kitchen's on a different level? Can they navigate their day-to-day life okay? Can they get done what they need to get done? Or are there things that they enjoy that their limited function along with their mental and emotional well-being and state is also challenged by? So as an example, maybe somebody is like, I just miss my group of women that I used to, do a Sunday night card game with. So sometimes if we can identify where their personal goal is, talking about going to the gym and doing exercise or signing up for some sort of, boot camp or spin class or yoga class even, but understanding where this person is and how cancer has impacted their personal life and goals. Are they able to meet their job requirements? Are they able to work their full day? Are they able to hang out with their kids or grandkids? And if we can start to connect the dots there, that is often a great way that we can improve their interest and adherence into exercise when they're having mental and emotional health challenges. And then on the flip side of things, it may not be the right time. And maybe something that we kind of chronicle away and just focus on the clinical side of where an individual is at, getting them to the next step, maybe bridging that conversation again with them, or again, potentially a caregiver down the road. But it's okay if not everybody is interested. It is okay that it's not the right time. And we may not be able to do something with this, even if we had exercise in a pill. It just doesn't work like that. So I hope this was helpful. And please, again, reach out if you have any other questions.
Dear Sami, we extend our heartfelt thanks once more for your valuable contribution, including your insightful and expert answers to the questions from our audience.
Thank you so much, Dr. Nigar, MedSynapse, for having me. Hope everyone has a great, great rest of your day.
Thank you so much once again, Sami. We're looking forward to many more great events together. And to our attentive audience, thank you for your listening and for your engaging questions. We hope this symposium has provided valuable knowledge to all of you. We conclude this session for the second OncoConnect Symposium. Have a wonderful day and see you soon on our next episode. Goodbye.